Good morning, everyone. And today our topic is the first thing which we are going to start is hematology. And in hematology, we are going to cover a number of things. But today we are going to start with full blood picture, which is also called as CBC. Okay, so they are more or less the same thing. So today we are going to start complete blood count. Okay, complete blood count or CBC. You can say this is not the accurate term because if it is a CBC, um, complete blood count, so it should just be limited to the counting of the blood cells, but it's not the case because um, they do give us a number of other things or number of other what you can say indices about the blood. So it is also called as okay. A better way to say this test is full blood picture, like sounds more accurate type of thing, which we are going to talk about. Okay, so complete blood count or full blood count or full blood picture. What is the importance of this thing? Because like this is one of the most requested blood testing which is done almost in every lab and in all the hospitals. They conduct thousands and thousands of CBCs or full blood FBP every day. So of course, this test, because it gives us a number of things. By the way, I would like to I'm going to add a photograph here just to show you like what are the things what are counted in full blood count. Okay, and this will be this one. So if you can see over here the full blood count or full blood picture or complete blood count, whatever, like they are the sum, they are the same things. It is the one of the most frequently requested tests in the medicine, and it contains a very, you can say, huge information about the components of the blood. And again, I'm showing you like what it comprises of. So a typical full blood picture comprises of the following test: uh, hemoglobin concentration, mean cell volume, mean corpuscular hemoglobin, packed cell volume or PCV, red cell distribution width or RDW, white blood cells, and also white blood cells. What they do is they count different type of double, like how many neutrophils are there, how many eosinophils are there, how many basophils are there. So they give us each and everything individually, a platelet count as well as reticulocyte count. So my way of teaching this thing is like how to approach a test result. Like I want the students to know how to interpret the blood reports. Okay, for example, if I'm going to teach you anemia only, okay, or if I will tell you, okay, these are the normal values and this will be decrease in this one, increase in this one, decrease in this one, increase in this one. So you don't have, you will not develop much concept, but I will take you in this way what you must do if you have a test report in front of you. And I will try to put some of the scenarios at the end of every unit. For example, when you are going to finish hematology, I will try to make one lecture. It's not a promise, but I will try to make one lecture in which I will include some of the blood reports. And of course, like that will be a good practice if it will be in a classroom. But now, of course, if we are not in the classroom, maybe I can do it myself in the lecture form, right? So I will try to do that. So simply by doing this test, we will be knowing how much red blood cells are there, what is the different other things, hemoglobin and all this stuff, white blood cells, platelets counts, and reticulocyte count as well. So, as you know, what is reticulocytes? Sites like these are the incomplete or immature red blood cells, right? Okay, how we do this thing, blood CP or FBP or CBC, whatever, simply they take up blood, of course, from the vein, and they nowadays, of course, they put it in a they put the blood sample in an automated analyzer, and it's a machine. Uh, I can again show you one Bing like how it looks like, right? Uh, just to like, by the way, it's not important, but um, like just to show you, analyze an analysis lab. Okay, so how it looks like is, um, of course, there are different models. Okay, like you can see over here, this is automated analyzer. So what they do, like they put the blood samples in this one, and simply it gives it print out the report nowadays. Of course, like, okay, so these analyzers are now so fast or so sophisticated. Uh, like basically they count the cells by a technique called as flow cytometry. And now I don't know, like, really what you guys know about the flow cytometry. Simply, uh, it catches the cells by their physical and chemical properties. A very simple way to tell you this thing. And nowadays, of course, like, they print out the report. So of course, like, this CBC or blood CP uh, is not the test which we do for to diagnose the like, not all the time it is used for the diagnosis, but of course um, it is done in healthy people as well, as a routine medical examination. Again, the same example, when you go to some other country, uh, for sure they will perform a CBC, just to see, like, if you are good or not. And just by this simple test, of course, I'm not saying like it is going to diagnose the condition, but it will, you can say, uh, it can guide you towards the diagnosis of anemia, towards the diagnosis of infection, towards the diagnosis of malignancies and things like this. So uh, many of the times this test is done to uh, you can say, um, see like how the disease is progressing, or when we are putting the patient on some medication like chemotherapeutic drug, we keep on performing this test as well. Many times this test is performed when you go for to donate the blood. Of course, they perform CBC as well as some other tests as well. So now I'm going to take you in a systemic fashion. Okay, and what I will be doing is, I will be going exactly in this way. See, the first thing which they give is hemoglobin. Okay, and I will tell you how to interpret hemoglobin. I will tell you how to interpret MCV. I will tell you how to interpret MCHN. I will take you in this way. I show you this photograph in the previous lecture, as well as I'll show you this one in the previous lecture. In this one, you can see there's just one abnormality, right? The lymphocytes are high. Rest everything is normal. Okay. Again, as I told you, if these results or these values doesn't match with your books, guys, don't blame me. Don't blame the book, because I told you they are different. And one of the thing I will show you here, for example, in this one it says hemoglobin percentage. The normal is between 11 to 13. But for example, here you will see 11.1 to 15.9, right? And here it says 13.5 to 18 in males and 11.5 to 16 in females. So see, these three are different, right? These two even are different. Okay. Same thing with neutrophils. Same thing with okay. For example, again, the WBC's count, for example, here this says the reference value is 3.54 to 10.8. So, or you can say 3,400 to 10,800, which is quite near to this value, 4,000 to 11,000. Just the difference is like 200, or which is quite same to this value. This one and this one is same, of course. Like this one is a little different. So, like what I remember, by the way, if you will ask me like what's the normal WBC count, my answer will be simply 4,000 to 11,000 cells per cube millimeter per millimeter cube. Okay, so my answer will be this thing. I remember this value. So you can see like the normal hemoglobin in males, females, of course, whenever it is less than this, anemia whenever it is more than this, polycythemia. Then mean corpuscular volume, packed cell volume, red cell distribution with white blood cells. Of course, I'm going to explain you these things. Don't think like I'm just passing them off. And then see white blood cell count, how many neutrophils are there, how many lymphocytes are there, how many eosinophils are there, how many monocytes are there, how many basophils are there. Now see the platelets even, 150 to 400. Here it says 150 to 379. Here it says 150 to 450. Okay, of course, like this one is given in cubic millimeter form, and here they have written in a different form per liter. Okay, so here they are talking about in 1 liter of blood how many platelets will be there, and here they are talking about if you will take 1 cubic millimeter of blood, how much platelets will be there. Reticulocyte count, okay, and ES. Okay, ESR is a different test, so don't include this one in this thing. So let's see the first thing, which is hemoglobin. Okay, hemoglobin. Now I think you guys know why hemoglobin is important. Anemia, right? So when we say that the patient have anemia, of course, like anemia is said like it is said like the patient have anemia when there is low level of hemoglobin. We said the patient have anemia, right? So one easy way to remember, guys, is simply we say that the patient have anemia is simply when the hemoglobin is see less than 13.5 in males, or less than 11.5 in females. Okay, for pregnant women, it's not the value, because uh, we say anemia, by the way, if I will tell you exactly, when it is less than 12 in females, okay, but less than 11 in pregnant females, because in females, in pregnancy, there is hemodilution, like the blood volume basically increases, there is more fluid, so the blood become diluted. So that's why in pregnancy it is considered when it is less than 11 gram per deciliter. So simply these are the cutoff values. Less than 13 gram per deciliter in males, you can say that the male have anemia, or less than 12 gram per deciliter, if it is the case, you can say that the a non-pregnant woman is having anemia. Okay, and what I am talking about is the values in adults. Keep this thing in mind. Pediatrics, they have different values, and if you want to see the values in pediatrics, of course you have to refer a book of pediatrics. Okay, so whatever I'm talking about the values in adults. Okay, now the important thing, see how we interpret anyone. You get the blood test results. Okay, you get the blood test results, you found that the HB is, for example, For example, okay, you get the blood result and you found that the HB in a male, uh, for example, 45 years of age, okay, of age, is 10 gram per deciliter. Now, what this person having, what this patient is having, of course, it's anemia, right? So now this thing is decided. Now this thing is done. Okay, this patient have anemia, right? Now, if you know from your knowledge how many kinds of anemias are there, you know there is microcytic, there is macrocytic, and there is normocytic. But before that, one thing which you should make your reflexes simply see the other cell types. Okay. What I want to say is, you get this report, you found that the HB is less. Quickly see either it is just the HB which is less, or either the WBCs are also less, or either the platelets are also less. There are three cell lines, right? Platelets, WBCs, and RBCs. So what I am saying, before deciding that if the person have anemia or doesn't have anemia, it's worth looking at the other cell types in the full blood picture. So what we want to see, either the problem is just with the red blood cells, or either the problem is with the red blood cells, white blood cells, and with the platelets as well. Okay. Why? Simply, again, see, I'm taking you in a sequence, okay? It's anemia, but stop here. Before making decision, it's worth looking other cells as well. Okay. Why? When you see the other cell types and you found that it's RBCs and WBCs and platelets all are reduced, then it's not anemia. Of course, it could be anemia, like of course a different type, but simply it will refer towards something, a disease of bone marrow. Okay. So, for example, if this is the case, then what you will go for? You will go for a bone marrow biopsy. See, in this case, if all the cell lines are decreased, then maybe the most logical thing is to do a bone marrow biopsy to see what's going on in the bone marrow, right? So, see, this is how we progress, okay? But okay, just give me some time. Okay, now the other case could be what? See, one case, all the cell lines are decreased. The other case could be what? If there is only low HB or low hemoglobin, okay, what should be the next thing? So what is the other case? The other cell lines are normal, but if there is only low hemoglobin, then your reflex should be see the reticulocyte count. Now, why this thing is important? What are reticulocytes? Reticulocytes are immature red blood cells, okay? And reticulocytes counts are increased when there is things like bleeding or hemolysis, okay? So anyone who is bleeding or hemolysis, what is hemolysis? Like more and more red blood cells getting destroyed in the body. Of course, right now our discussion is not hemolytic anemia, so I'm not going to go in detail of that. And see, simply a history can distinguish between what you can say, between a hemolysis or hemorrhage. Of course, if the patient have hemorrhage, he will say that, yes, I got trauma and there was bleeding. But hemolysis is something going on inside the body. So see the reticulocyte count. Now, the important thing over here is like if you found reticulocytosis, what is reticulocytosis? Increased reticulocyte count. Okay, it means that more and more red blood cells are formed in the body, in the blood, and that means like more and more immature cells are circulating in the blood, which means that the bone marrow is functioning fine, which could be found in the cases like hemolysis or hemorrhage. Understand? See, the thing is easy. But if you found uh, reticulocyte count is not elevated or is not increased, what it means? It means simply that the bone marrow is not making new RBCs. Okay, it implies what? That there is no new erythrocyte production. So what should be your next step? Okay, so your next step should be look at the size of the erythrocytes. Now, what is erythrocytes? Again, it is the other name given to RBCs. Okay. Now, guys, look this one. I get the test result. I found hemoglobin is low. I quickly see what is the condition with WBCs and platelets. Okay, they are normal, so that's fine. I will see the reticulocyte count. So reticulocyte count, I will simply go and oh wait, where is RBCs, hematocrit, MCV, RDW? Okay, in this one they are not given. Okay, so simply I will go and I will see the reticulocyte count. Even this one they are not talking about, but in the blood, okay, reticulocytes. Okay, so if I found like the reticulocytes count is increased, so it means like it could be hemolysis or hemorrhage. But if the reticulocyte count is decreased, it means that the bone marrow is not making enough red blood cells. So the next thing I'm going to see the size of the RBCs, and how I can know about the size of RBCs by looking MCV. So what is MCV? How we look? We look mean corpuscular volume. What is corpuscle? Corpuscle is the cell. So what they do, they take many RBCs and they measure what is the volume of each RBC. Okay, so normally you can see over here the normal MCV is from 76 to 96. Here you will found 79 to 97, and here you will found okay, here they have not given, so I will tell you a value which you will agree and many books agree with me, 80 to 100, the easiest way to remember, femtoliter. So this is the normal RBC size. Whenever it is less than 80, we call it as microcytic, small cells, less than 80 femtoliter. Whenever it is more than 100, we call it as macrocytic. The cells are bigger, more than 100 femtoliter. And whenever it is between 80 to 100, it is called as normocytic. Means the cells are normal size. So 80 to 100. I hope you understand this thing. Now, guys, you found that the cells are small, and how we characterize anemias. We divide anemias into three big groups by looking at the size of the red blood cells. In microcytic anemia, the red blood cells are small. In normocytic anemia, they are normal in size. In macrocytic anemia, they are large in size. and that we came to know by seeing the MCV. Okay, so remember that MCV provides the measure of average cell size. Okay, and this is reliable in most circumstances. But for example, okay, now if you know what are the causes of microcytic anemia, iron deficiency anemia, lead poisoning, thalassemia. Okay, the mnemonic is TAILS, by the way. T for thalassemia, A is for anemia of chronic disease, I is for iron deficiency anemia, L is for lead poisoning, and S is for sideroblastic anemia. What are the causes of macrocytic anemia? Vitamin B12 deficiency anemia, folate deficiency anemia, alcoholic people, liver disease, okay, and many drugs. What are the causes of any normocytic anemia? Again, anemia of chronic disease, drugs can give, bleeding, hemorrhage can give, hemolysis can give, right? Normocytic anemia. So, what they do, by the way, for example, they take the blood sample and they measure few of the cells and they measure how much is their volume, and then uh, it's not like this that all the cells they will be like they will be the size of 76. Maybe there are cells which are the size of 73. Maybe there are cells which are the size of 74, 75, 76, 77, 78. But what they do, they take the mean and they give you the mean value. Now, I will give you an example. For example, we have shapes. We have three cells. Okay, so one of the cell is this size. Okay, copy, and I'm going to paste it over here again. Okay, sorry. One of the cell is this size. Okay, and one of the cell is this size. Okay, and the third cell is simply this size. Sorry, this one is, by the way, too small. Okay, consider it as round, right? So we take three cells. Okay, take three cells. For example, this is 100, this is 50, or for example, this is 200, this is 150, and this is 100. So how we take the mean? We will take 200 plus 150 plus 100 and we will divide it by 3. So what we will get the final value? We will get the value will come back as 150, right? So which is the mean. For example, someone have microcytic anemia. So most of their cells will be less than 80, so they will be of this size. Normocytic, this one, considering this is 80 to 100, okay, and macrocytic, this one. What will happen if someone have mixed anemia, anemia of iron deficiency anemia with iron deficiency anemia with vitamin B12 deficiency anemia? So they will be having a lot of cells which will be big, a lot of cells which will be small. So when they will take the mean, maybe the value will be normal. Okay. So which means that if a patient have two ongoing pathologies like iron deficiency anemia with vitamin B12 deficiency anemia, then this MC will be unreliable. So why? Because they have low MCV cells, they have high MCV cells, and when we will take the average, it will be normal. For this reason, we include one more thing that is called as RDW. Okay, here you can see red cell distribution width. Okay, so for this reason, we have the third thing that is called as what? Red cell distribution width. It is also called as what? RDW. This gives an indication of the distribution of red cell size. Okay, what I mean to say, if this picture is present, like there is very big cells and there is very small cells, then this value will be increased. Okay, or this value will be increased. Okay, so that's why if RDW is increased, we cannot trust MCV. If RDW is normal, we can trust MCV. Okay, so that's all about, you can say, the diagnosis, the initial diagnosis of anemias. Okay, simply guys, this is the way we go and we reach the diagnosis. So now I will talk about anemia, just the classification. What I told you, microcytic, right? Normocytic and macrocytic. Okay. Guys, what are the causes of microcytic anemia? Sorry. Okay. What are the causes of microcytic anemia? Remember the mnemonic tails, but I don't like this mnemonic because this one is not in the arrangement. Remember in this way, like the most common cause is iron deficiency. Okay. Then there is thalassemias. Then there could be lead poisoning. Then there could be anemia of chronic disease, and there could be sideroblastic anemia. Okay, these are the causes of microcytic anemias. So, and I told you what is the story behind this thing, how you can reach this conclusion that the patient has microcytic anemia. When it comes to the normocytic anemia, it could be chronic disease anemia. It could be hemolysis or hemolytic anemia. It could be hemorrhage. Okay, and it could be bone marrow infiltration. Okay, when it comes to the macrocytic anemia, then uh, the story is a little different, but I will tell you, because microcytic can be megaloblastic or non-megaloblastic. We will discuss it later, but for now, it could be vitamin B12 deficiency, it could be folate deficiency, it could be alcohol usage, it could be hypothyroidism. Okay, uh, it could be multiple thyroidism. It could be multiple myeloma, and it could be like myeloproliferative disorder, myeloproliferative disorders. Okay, and it could be drugs even. Okay, of like drugs causes folate deficiency, so that doesn't make any difference. Okay, so this is how we will reach to this stage, that okay, the person have anemia and of what category. Now guys, see, if you diagnose that the person have microcytic anemia, now you have to further diagnose either it is iron deficiency, either it is this or this. If you diagnose someone have this thing, you have to further diagnose either the patient have this or this. So of course further explanations are needed. For example, uh, if you diagnose that someone have microcytic anemia, so as I'm teaching you how to approach the test, so that's why. So if you diagnose that the person have microcytic anemia, so what is the most common cause? Iron deficiency anemia. So of course, you must do some testing uh, to find out the cause, right? So uh, to finally reach our conclusion that the person have iron deficiency anemia, we are going to find out the deficiency of iron in the body. Okay, so now see, iron deficiency can be due to diet, iron deficiency can be due to cancers, iron deficiency can be due to chronic blood loss, iron deficiency can be due to multiple other reasons. Of course, like our discussion is not iron deficiency anemia. So what we do, uh, some baseline knowledge, of course, like what you many medical students say, and I always say that basic sciences plays a lot of important role. For example, we must have the knowledge of like if we are talking about iron deficiency anemia, like where the iron get absorbed in the GIT. So that can help in localizing the pathology. For example, the iron is absorbed in duodenum and jejunum, whereas vitamin B12 is absorbed in terminal ileum and folate is absorbed in small bowel. So talking about iron deficiency anemia, what you will go do, you are going to do perform what? Iron studies. Okay. Now to establish your diagnosis, you will further decide. You get the CBC report. You found, okay, you reach that, okay, the patient have microcytic anemia. Now you know by your knowledge that the most common cause of microcytic anemia is iron deficiency anemia, or it's not always like this. For example, you have done the history taking, you found the pallor, it's a baby, and you know that the baby is completely on cow milk, and the baby belongs to a poor family, so you are thinking about iron deficiency anemia. But it's very common type of anemia worldwide, especially in developing countries. So now see, again, a lot of baseline knowledge is needed. You must know the understanding of how your body handles the iron. Okay. Uh, well, first of all, the important thing I told you, the iron is absorbed in the jejunum, or you can say the upper portion of small bowel, and it is absorbed in ferrous state, Fe2 plus state, and then it is transported across the intestinal cell into the plasma, and in the plasma, it is carried to the developing red blood cells by what? By a protein called as transferrin. Okay, and then the iron is stored. The extra iron is stored in the body in the form of ferritin and hemosiderin. Okay, and red blood cells have transferrin receptors on them, which are also called as soluble transferrin receptors. Okay, which can be measured in plasma. So of course, like all this informations are needed. So simply, uh, guys, whenever uh, you found that the patient have iron deficiency anemia, what you will do, you are going to do iron studies. Okay. Now again, I will take the help of Bing and I will show you what is iron studies reports looks like. Okay. So you can see the image over here. When you are going to perform iron studies, you will found they will give you the result as iron transferrin, which is a protein which helps the what you can say transfer of iron. Then they tell you the transferrin saturation, how much transferrin is attached with the iron. Of course, when the iron is less saturation is there, so this value will be more. So ferritin, which is the stored form, and then the soluble transferrin receptors, which are the receptors on the RBCs. And whenever like there is body is in less iron state, what happens, like RBCs express more and more soluble transferrin receptors, or which can be measured in the blood. Okay, so these all things will be given in the test, or you can see like a lot of things you can found. See uh, what will happen to iron, total iron binding capacity. Okay, ferritin and hemoglobin, electrophoresis, and thalassemia. Of course, like I don't want to talk about that thing now, but I'll iterate again. See, these are the things which they give us when we measure the iron. So whenever we go for iron studies, guys, we ask the lab that, okay, we want the iron studies of the patient. They give us serum iron levels. They give us serum total iron binding capacity. So of course, like when the iron is less, this capacity will be increased. Whenever the iron is more, this capacity will be reduced. They will give us serum ferritin. Okay, they will give us transferrin saturation, and they will give us serum soluble transferrin receptors. Okay, so all the things they are going to give us. So what will happen when the iron level in the body is reduced, or there is iron deficiency anemia? What will happen? Serum iron will be reduced. Okay, what will happen with the total iron binding capacity? It will be increased. Why? Because the body is trying hard to bind any iron in the system. Okay, so of course, like this one will be increased. What will happen to serum ferritin? It will be reduced. Okay, because the iron stores are low. What will happen to the transferrin saturation? It will be reduced because less transferrin saturated with iron. And what will happen to soluble transferrin receptors? They will be increased. Okay, so simply why? Because the red blood cells, they are attempting to absorb any iron in the system, so they are going to express more and more receptors, and more receptors are going to form in the blood. So now here comes many other issues as well. For example, if you will ask me what is the best test among these things, so see, what if before giving the blood to the labs you had a very iron rich meal, or for example you took one tablet of iron, your serum iron will be high, or not show the exact uh, condition of iron stores in the body. So that's why the best test, or the best measure, or the single best test, which we can rely on, is the serum ferritin level. Ferritin level is the best, you can say, single test for iron deficiency. But again, this one also has some issues. I will tell you why. Okay, so if for example the level of this one come back as less than 15 microgram per liter, it is suggestive of iron deficiency. Okay, but I will tell you one more confusing thing. Again, depending on your level of knowledge, if you know what is acute phase reactants. Acute phase reactants are different proteins in the body which increases with any infection, inflammation, or malignancies. Okay, for example, one of the thing, C-reactive protein. Okay, what is C-reactive protein, or what is ESR? Whenever there in the body there is any infection, inflammation, or malignancy, CRP and ESR get raised. Okay, remember guys, ferritin is also acute phase reactant. So whenever there is any infection, inflammation, or malignancies in the body, so the ferritin level will be raised in the blood, no matter if there is even iron deficiency. So in the cases of active inflammation, okay, so what I'm saying, in the cases of active inflammation, you can say we cannot rely on serum ferritin. Why? Because they may be uh, falsely raised because of acute infection. So acute inflammation, or you can say acute infection. Okay. So in these cases, we cannot rely on this thing. So in that case, we are going to rely on this thing. So soluble transferrin receptors will be the best, you can say, indicator. Sorry, you can say best predictor. Okay, for in these cases. Okay, of course, like this will be the best one in that cases. So serum soluble transferrin receptor, it is not available routinely, and of course, we don't do it routinely. Rather, the clinician, they decide either that is needed or not. Okay, uh, so sometimes it can be difficult to be sure that the patient is iron deficient in such circumstances. Okay, but in that case, okay, you can start a trial of iron treatment. So this thing is the way. So of course, if there is diagnostic uncertainty, even after this, we can go for bone marrow biopsy. Okay, of course, like in that case, like we will not found any iron in the bone marrow. Okay, so like that is one of the tests, by the way. So it's not like this that if you are talking about iron. Okay, one more thing, then we are going to close this lecture. Like what I wanted to talk about is abnormal iron states, okay, in the body. For example, I will tell you, um, in the conditions like chromatosis, okay, which is like a genetic condition in which like there is abnormal iron metabolism in the body, or uh, or conditions in which the people, they are getting multiple transfusions or repeated transfusions every week, for example, in thalassemia, or for any other blood condition. You can say multiple blood transfusions, okay, multiple blood transfusions. Of course, like in these cases, uh, can lead to iron overload in the body. Okay, so what happens like in these conditions, there is iron overload in the body. So what happens, like you will found like the serum iron, ferritin, transferrin saturation are raised, as well as total iron binding capacity will be reduced. Or you can say, I can copy all these things over here, or and then I will tell you what is the condition in these patients over here. So whenever like this is the case, uh, so whenever this is the case, what will happen? This will be raised. Okay, serum total iron binding capacity will be low. Okay, as well as you can say serum ferritin will be uh, raised. Okay, transferrin saturation will be uh, increased or high. Okay, and soluble serum transfer receptors will be, of course, like low level, like low or normal, of course, like because the cells, they are not forming like the normal level of that they are forming. So this will be the picture uh, in that case. Okay, so uh, whereas like if the patient have anemia of chronic disease, the condition will be different. Of course, like in that case, iron will be normal, total iron binding capacity will be maybe normal, serum ferritin will maybe increase because it's a acute phase reactant, transferrin saturation will be reduced, and soluble serum transferrin factors will be normal. So that's all about iron, and in the next lecture we will start discussing the second type, which is the macrocytic. Okay, and then we will discuss like so on and so forth. So I hope you understand this lecture well. So thank you so much, guys, for listening.